صوت مؤذي.
الصوت واضح دكتور؟
لسه واضح.
واضح هسه؟ أبدي هسه أستاذ؟
تفضلي.
Okay. Good morning, everyone. Today, I would like to present my subject about the embryological development of the heart and its formation from A to Z. Previously, we have talked about the anatomy of the heart and the vascular system in general. Today, I will describe the basis for the formation of each one of its parts and the pitfalls that could occur during this, leading to the congenital defects. Somewhat is a complex subject, but I will try to simplify it as much as possible. First of all, let's have just a brief explanation about the embryo. Now, as we know, the embryo is composed of 3 layers, from the ventral to dorsal. That is the endoderm, mesoderm, and the ectoderm. Now, the mesoderm itself is composed of the 4 parts: paraaxial, intermediate, mesodermal plate, and the extra-embryonic part. Now, with the further differentiation, the lateral plate mesoderm will be differentiated into the subclinic layer and the somatic layer, with the formation of the intraembryonic cavity in between. Now, with the further development, the endoderm will the subclinic layer will grow toward each other, toward the center, fusing with each other, leading to the formation of the central canal, that is the foregut and the yolk sac, which is separated later. On the other hand, we will have the ectoderm with the somatic layer. This also will grow toward the center from both sides, so it fuse with each other, lead to the formation of the complete tube, with the original intraembryonic cavity now became the pericardial cavity. Now, the vascular system will begin to form at the middle of the 3rd week, that is about the 16 or the 18 days, where the embryo will not be able to meet its nutritional requirement by the diffusion from the mother alone. And the heart will start to beat the blood spontaneously by day 21 or 22. Now, as we know, for the formation of any organ, we need a primary cell. Here we have what is called the progenitor heart cells. Actually, these are present in the epiblast, about in this region, that will be the caudal end of the primitive citric. Now, these cells will start to migrate gradually toward the subclinic layer of the lateral plate mesoderm. So here it will form a horseshoe-shaped crest of these cells that is called the primary heart field. This occurs at about day 16. Now, these cells, it will begin to be specified from both sides, as initially we will have formation of the 2 primitive heart tubes. So specify from the both sides into the atrium, left ventricle, and the most of the right ventricle. Now, on the other hand, we will have another group of these cells that is called the secondary heart field. These also reside in the subclinic layer, just posterior to the pharynx. And these will appear later at about day 20 or 21, later than that of the primary heart field. These will be responsible for the formation of the remaining of the heart, the remained part of the right ventricle and the outflow tract. Also for the lengthening of the outflow tract, and also exhibit the laterality. What I mean by the laterality is the specification of the heart into the left and the right side, so that those cells that lie on the right side will contribute to the left or the outflow tract, while those lie on the left side contribute to the right side. So now, as we said, once the primary heart field cells have been established, they will be induced, it will be induced by the endoderm layer to form the cardiac myoblast and the blood island. These will later on form the blood cells and the vessels by the process of the vasculogenesis. Now, with the time, these blood islands will unite together on both sides, causing formation of the endothelial-lined tubes from each side. Now, these cells, it will lie in the area called the cardiogenic area, surrounded by the intraembryonic cavity that will cause the formation of the pericardial cavity. Now, we have tubes from each side. They will start to migrate toward each other, as we said, by the folding of the embryo toward the center. So they will migrate toward each other to the center until they will fuse. That will lead to the formation of the single primitive heart tube. This primitive heart tube, it will bulge into the pericardial cavity more and more, but it will remain attached to the posterior surface of the pericardial cavity by the mesodermal tissue that is called the dorsal mesocardium. Actually, there is no ventral mesocardium will be formed, just the dorsal mesocardium. At the same time, we will have the central part of this heart tube will expand, so that the heart tube will be just an expanding continuous tube composed of the inner endocardium and the outer myocardium. Now, with the time, there will be disappearance of this dorsal mesocardium. So there will be formation of like a sinus called the pericardial sinus, connecting both sides of the pericardial cavity. So by this, we imagine that the heart tube now is lying free within the cavity with the disappearance of this. Actually, it is not, but it will be suspended inside the cavity. If we look from the lateral view, it is suspended inside the cavity by its attached blood vessels at its caudal and the cranial end, so that the heart tube will receive the blood from the caudal end, pushing it toward the cranial end through the aortic arch into the dorsal aorta posterior to it. Of course, we have foreguard is formed between these two structures. Now, at the same time, we will have the myocardium. It will begin to thicken. It will secrete a layer of the hyaluronic acid that is called the cardiac jelly that will separate it from the endocardium. Meanwhile, we will have another group of the cells that is present in the septum transversum, just anterior to the pericardial cavity. If we look, because now we look at it from the interior, we don't see it. If we look at from here, so these cells from here, it will migrate to the caudal end of the tube. It will form what is called the proepicardium. And they will start to migrate over the heart tube to form most of the epicardium. The remaining part of the epicardium, it will be derived from the mesothelial cells of the outflow tract. I mean from the inside of the heart tube itself. By this, we will have formation of the single heart tube composed of three layers: endocardium, that is the endothelial lining; myocardium, that is the muscular layer; and the epicardium, the outer layer. And this outer layer will be responsible for the formation of the coronary arteries. Now, where the heart tube lie exactly? I mean, what is its relation to the other organs? Now, initially, the cardiogenic area and the heart tube, it will lie anterior here, anterior to the oropharyngeal membrane and the neural tube that is formed from the ectoderm. Now, with the closure of the tube and the formation of the brain vesicle, now this central nervous system will start to migrate cranially toward the head, so it will ident over the cardiogenic area, pushing it posteriorly. So with the rapid formation and the cephalic folding of the embryo, so the oropharyngeal membrane will be pulled forward while pushing the heart toward the cervical region and finally to the thoracic region. Now, disruption of the laterality pathway, I mean the specification to the on the left side, will lead to the many defects, of which what is called atrial and ventricular isomeria. What we mean by this, that both atria and the ventricles, they will have the same characteristics. Yeah, mean that there is no difference between the right and the left side, so that they will look like a mirror image of each other, as we see here in those pictures. There is no difference that we suspect between the right and the left side. Another defect that is called ventricular inversion. Now, in this defect, there will be change in the position of the ventricles, so that we will have the left ventricle connected to the right atrium through the mitral valve, while the right ventricle connects to the left atrium through the tricuspid valve. This condition is also called the ill transposition of the great vessels. That is a rare condition, because now we have the pulmonary trunk arise from the left ventricle, while the aorta arises from the right ventricle. And this occurs because of the change in the position of the ventricles, while the position of the vessel themselves is normal. Now, after the formation of the straight heart tube, there will be beginning of the process of the looping. Now, as we said, the lengthening of the heart tube is added by the secondary heart field cells. So the heart tube, it will begin to bend on the day 23. How this will occur? We will have the cephalic portion of the tube, it will move downward and to the right, while we have the caudal portion will move upward and to the left. And this will complete by day 28. So as we look here, this is a single heart tube straight. Now it begins to loop with the caudal, with the cranial portion down and the caudal portion up. Now, during this time, there will be formation of the local expansion along the tube, beginning with the atrium. Initially, the atrium, it is just a paired structure lying outside the pericardial cavity. Now, with the looping process, it will become incorporated inside it. The junction between the atrium and the ventricle is narrow, and this will form the atrioventricular canal. The third part we have is called the bulbous cordis. This part will be responsible for the formation of the outflow tract. Now, it will be divided into three portions. The proximal portion, the largest one, will form the trabeculated part of the right ventricle. The conus cordiae, that will form outflow tract of the both ventricles, and the distal portion, that is the truncus arteriosus, that will form the root and the proximal portion of the aorta and the pulmonary artery. Now, the junction between the ventricle and the bulbous cordis remain narrow. This is called the bulboventricular sulcus, and it will form the interventricular foramen. Now, because this we have the primitive left ventricle and we have the right ventricle, so this is called the interventricular foramen. Now, after the looping process, the smooth wall of the heart, it will begin to trabeculate, both on the proximal and the distal portion of the interventricular foramen. Now, initially, the bulbous cordis, it will remain smooth walled, but the trabeculation, it will occur in the primitive ventricle, so by that now it is called the primitive left ventricle, while the trabeculated part of the bulbous cordis will be called the primitive right ventricle. Now, as we said, the looping, it should occur toward the right side. Now, if the looping occurs toward the left side instead of the right, it will lead to the condition called the dextrocardia, where we will have the heart will lie on the right side of the chest. Now, this condition, either it will occur during the looping process, or it will occur during the establishment of the laterality, or during the process of the gastrulation. That means the single layer embryo will be differentiated into its three layers. And this condition, either it will occur as a part of the sinus inversus, that will be a complete asymmetry of the all organs, or it will be associated with the change in the position of some organs. This is the PHS X-ray showing the heart on the right side of the chest. Now, formation of the sinus venosus. What I mean by this is the formation of the venous inflow of the heart, the opening for the superior and the inferior vena cava. How it will occur? In the middle of the 4th week, we will have a sinus venosus. This is the sinus venosus connected to the atrium. Now, this sinus venosus will receive the blood from the 2 sinus horns, right and the left. And these horns will receive the blood from 3 veins: the vitelline vein, umbilical vein, and the common cardinal vein. Now, initially, the junction of the sinus venosus with the atrium is wide and central. What will happen later, when we will have a shunt of the blood from the left to the right side, that will occur in the venous system at about the 4th or the 5th week. So this will cause this opening to shift toward the right side. At the same time, it will cause degeneration of the left sinus horn, with the obliteration of the left vitelline vein during the 5th week and the common cardinal vein during the 10th week. Now, all that remain of the left sinus horn, it will be the oblique vein of the left atrium and the coronary sinus. And this will be the side of the venous drainage of the developed heart. Now, at the same time, due to the shunt from the left to the right side, there will be enlargement of the right sinus horn. So it will be incorporated into the wall of the right atrium to form a smooth walled part. And its entrance into the atrium, that is called the sinoatrial orifice, is flanked from both sides by the venous valves that is fused at the superior part, forming the septum sporium. Now, with the further development, what will happen that the left venous valve with the septum sporium will be incorporated into the atrial septum, while the right valve, the superior part will be obliterated. The inferior part will be differentiated into 2 parts: valve for the inferior vena cava and the valve for the coronary sinus. At the same time, we will have formation of what is called the crest terminalis. This will separate the smooth wall part from the trabeculated part of the right atrium. Now, after the formation of the external contour of the heart, we will have the formation of its internal architecture. So we will have first the septa of the heart that will be formed between 27 to 37 days, when the embryo will grow in length from 5 million to 16 to 17 million. Now, the formation of the septum in general will occur in 2 methods. Either there will be rapidly active developing tissue mass from both sides that will grow toward each other until they will fuse in the center, dividing the lumen into 2 canals, or there will be one active tissue from one side that will grow toward the other side fuse with.
صوت راح وقت الذروة.
نعم. العفو دكتور، ماكو صوت.
بس دا يروح ويرجع. اوكي اخذي راحتك كملي. دكتورة هنيدة، استاذ محمد، دا تسمعون؟
استاذ يمكن راح الصوت.
راح صوته.
اي راح.
هسه دكتور بتسمعون صوتي؟
هسه اي اوكي.
طيب. نعم. طيب. So,
شوفيك حمادة قلت
So we will have
أنا ما
two
طلع
active
المشرع عليك ولا
tissues.
المايكات مالتكم على السايلنت رجاء.
أحد منكم فاتح المايك؟
سدوها المايكات. يلا تفضلي دكتورة هنيدة.
Okay, doctor. Now, as we said, we will have two tissue masses, the endocardial cushions. These will be formed in both the AV canal and the conotruncal region. So this will be responsible for the formation of the atrial and the ventricular septum, and for the formation of the valves and the pulmonary and the aortic channel. Now, another method for the formation of the septum does not involve these endocardial cushions. What will happen here that we will have one part of the wall of the atrium of the ventricle, it will fail to grow, while the other parts will continue to expand. Now, this will lead to the formation of the ridge, with the two walls will oppose each other, merge, and in the midline, leading to the formation of the septum. Now, this septum will never form a complete partition between the two arteries, and it will leave just a small opening that will be later on closed by the proliferation of the tissue from the neighboring. Now, if we take the septum formation in the common atrium, this will be a complex process. That is, at the end of the 4th week, what will happen that we will have a sickle-shaped crest. It will grow from the roof of the common atrium toward the center, toward the endocardial cushions, but will never fuse with it. So it will cause the formation of the septum primum, leaving an opening that is called the ostium primum. So the ostium primum is an opening in the septum primum. Now, with the extension of the tissue from the endocardial cushions, this will cause the closure of the ostium primum. But at the same time, we will have another event that will be the cell death in the septum primum that will cause the formation of the ostium secundum. So by this, we will have closure of one opening, formation of the other. But notice that the ostium secundum is an opening in the ostium primum, not in the septum secundum. Now, with the further expansion of the right atrium, there will be formation of another fold that is called the septum secundum. This also will never separate the atria completely, and it will leave a small opening that is called the foramen ovale. Now, when the upper part of the septum primum will disappear, the remaining part will form the valve for this foramen ovale. So that by this, if we look at the if we look from here, now the connection between the both atria, it will be just an elongated cleft that will be have a valve that will allow for the passage of the blood from the right to the left side. Now, after the birth, when the lung circulation begins and there will be increase in the pressure in the left atrium, we will see that this valve of the foramen ovale, it will press against the septum secundum, okay, that will fuse with it, leading to the obliteration of this foramen ovale. Now, in about 20% of the cases, this fusion will never be complete. And yes, it will be incomplete, so that it will remain patent in condition that is called the propatency of the oval foramen, allow the connection between both atria. Now, with the further differentiation of the atrium, as we said, while the right atrium is expanded by the incorporation from the right sinus horn, there will be expansion also of the left atrium with the formation of the single primitive pulmonary vein that will gain access to the lung. Now, With the further differentiation, there will be 4 pulmonary veins incorporated into the wall of the left atrium instead of 1 vein. And this will lead to the formation of the smooth wall of the left atrium. So that now in the developed heart, we will have the primitive left atrium will form the trabeculated atrial appendage on the left side, and the primitive right atrium will form the trabeculated atrial appendage on the right side. While the smooth part, it will be derived from the right sinus horn, as we said, from the right side, and the pulmonary veins from the left side. Now, the septum formation in the AV canal, I mean between the atrium and the ventricle. What will happen is, at the end of the 4th week, there will be formation of 2 mesenchymal tissues at the anterior and the posterior border of the AV canal that are called the superior and the inferior endocardial portions. These are the superior and the inferior endocardial portions. Now, initially, as we said, the access to the AV canal is only to the left ventricle, to the primitive left ventricle. That will be separated from the bulbous cordis or the right ventricle by the bulboventricular sulcus initially. Now, with the further development, there will be degeneration of this sulcus, leaving only a flank on both sides, so that the posterior end of this flank will end at the superior endocardial quotient. So by this, we will have the access not only to the left ventricle, but also into the right ventricle. Now, with the time, these 2 quotients will grow toward each other, fuse with each other into the right and the left part. Now, after the fusion of the endocardial quotients, formation of the 2 orifices, there will be proliferation of the mesenchymal tissue over these orifices. With the flowing of the blood through the orifice, it will cause thinning of this tissue on the ventricular surface. So it will cause formation of the valve that remain connected to the ventricular wall by the muscular cords. With the time, there will be degeneration of this muscular cord and will be replaced by connective tissue. So by this, we will have a valve composed of the connective tissue connected to the wall of the ventricle by the cord tendoning. By this manner, we have bicuspid valve on the left canal and we have tricuspid valve on the right canal. Now, we have a group of the defects that will constitute an atrial septal defect. And one of the most significant defects is that involving the ostium secundum that will cause a large opening between the right and the left side. And this will be occur either due to the excessive resorption of the septum primum or due to the absence of the formation of the septum secundum. The problem is when there is a complete absence of the atrial septum. This will lead to the very serious defect that is called the common atrium, and this will be associated with the other defects in the heart. Now here we have defect in the ostium secundum with the connection between both atria, and here we have a complete absence of the atrial septum with the formation of the common atrium, as we see here. Now, occasionally the oval foramen will close before its time. That is called the premature closure of the oval foramen. So by this, we suspect what? When there is a premature closure of the oval foramen, which will cause the shunt of the blood from the right of the left side, and when it closes prematurely, it will lead to the hypertrophy of the right side of the heart with the underdevelopment of the left side. Death usually will occur shortly after the birth. Now, as we said, the endocardial quotients, it will not only cause the division of the AV canal into the right and the left side, but also these quotients will participate in the formation of the membranous portion of the ventricular septum and in the closure of the ostium primum. So normally, this area should have a cross shape that will be formed by the atrial and the ventricular septum and the AV cushions. And the integrity of this cross is an important sign in the ultrasound examination of the fetal heart. Now, if these cushions will fail to fuse, it will lead to the formation of the persistent single AV canal that will be separated by just an abnormal valve leaflet. If we look here we have a common single AV canal separated by the one valve from each side, one leaflet. Now, sometimes endocardial cushions will partially fuse. That will close the ventricular side, but the atrial side will remain open. This is called a defect of the ostium primum that is usually accompanied by the cleft in the anterior leaflet of the tricuspid valve. Now, another defect is the tricuspid atresia, where we will have an absence of the tricuspid valve with the obliteration of the right orifice. So what will happen here? When we will have an absence of this valve, the only access from the right atrium will be through the patent forming ovale to the left atrium. And this will cause the hypertrophy of the left ventricle with the underdevelopment of the right ventricle. Another defect involving the tricuspid valve is called the Episteme anomaly. Here we will have the tricuspid valve will be displaced downward toward the apex of the right ventricle, so that it will lead to the enlargement of the right atrium in a condition that is called atrialization of the right ventricle, while the left ventricle will remain only a small part that is functional. This is the chest X-ray appearance of the Episteme anomaly with the rounded contour or the box-like heart with the decrease in the pulmonary vasculature. Now, septum formation in the truncus arteriosus. The truncus arteriosus, as we said, it will lead to the formation of the outflow tract. What we will have here, we will have a pair of the ridges that will be formed in the truncus. One on the right superior wall, that is called the right superior truncus swelling, and one on the left inferior wall that is called the left inferior truncus swelling. Now, with the further development, the right side will grow distally onto the left, while the left side will grow distally onto the right. So they appear like they will twist around each other. This will lead to the formation of the spiral septum that will divide the lumen of the truncus into the aortic channel and the pulmonary channel. Now, while we have formation of the truncus swelling, we will have a similar swelling. It will appear in the conus. That is the right dorsal one and the left ventral one. With this time, these will go toward each other, fuse with each other, so they will divide the conus into two parts. One is the anterior lateral part that will form the outflow tract for the right ventricle, and one, the posterior medial part that will form the outflow tract for the left ventricle. Now, the formation in the ventricles is more than that the atrium. That when we say that when there will be expansion of the both ventricles, part of the wall will fail to grow. So the both walls, they will merge with each other, forming the muscular portion of the interventricular septum. This also will not be complete. It will leave an apical cleft between both ventricles. That is called the interventricular foramen. Now, with the extension or proliferation of the tissue from the endocardial portions to the muscular portion, it will close this interventricular foramen, leading to the formation of the membranous portion of the interventricular septum. Now, semilunar valves, the aortic and the pulmonary valve, it will be formed when there is a complete partitioning of the truncus. Yani, the separation into the aortic and the pulmonary channel. So we will have a small tubercle. It will appear on the top of the truncus swelling from each side, grow toward each other, and a third tubercle, it will appear opposite to this. So with the time, this tubercle will hollow from its upper part, leading to the formation of the semilunar valve or the 3 leaflet valves. Now, the atrial or the ventricular defects, septal defects, either it will involve the muscular portion that occur in about 80% of the cases, or the membranous portion that will be the most serious one. Actually, depending on the size of this opening, the blood from the pulmonary artery will be about 1.2 to 1.7 that carried by the aorta. This is a defect involving the membranous portion of the heart with the connection between both ventricles. Now, teratology of valve. This is the most frequent abnormality of the conotruncal region. That is for the outflow tract region.
العفو هنيدة، بعد اكو هواي بعد دكتورة هنيدة، بعد عندك هواي؟
والله دكتور لا، يعني ما انفصل وين وصلت الصور بعد يعني ربعة او هيك شيء.
هواية كلش استاذ محمد.
عين استاذ رعد.
نكمل؟
لا كيفك اذا تريد نسوي جزء ثاني تكمله على غير وقت.
اي والله، لانه هو هذا الموضوع كلش لطيف وبديع، شلون الواحد يعرف هذه، بس من يصير ماده هوايه يمكن ما يفتهموها. شو تقولون، تكملون لو نخليها
براحتكم يا استاذ.
خلي نأجله على سيشن ثاني، ماكو مشكله.
نأجله على سيشن ثاني وسوي كويزات بيه للطلاب،